Hi guys, my name is Jill. I'm one of the infusion nurses from Pediatric Home Service. I'm going to try to talk loud. I know the music is kind of, you guys can listen to the music or you can listen to me. So anyways, I want this to be interactive, you guys. So if you have questions, anything you want to ask as we're going through it, please ask. First, I'd like to just start off by asking, who here has heard of Pediatric Home Service or PHS? Most people, there's a few that haven't maybe. So anyways, it's just going to kind of tell you, most of you guys are from the hospital setting, whether it's Amplats or Children's or wherever you come from. We are in the home care setting, so once you guys discharge your patients home, we're the ones who take over managing those patients from an infusion standpoint at home. So I'm just going to kind of talk a little bit about that and what we do what kind of all about PHS and our team at PHS. So you can follow along with the slide presentation also. We basically provide compassionate, specialized, high-tech care in the home environment where we really strive to allow the children to live quality life. They're out in the community, they're at home with their families, and that's our goal, is to get them home. I know that's your goal too, is to get them home and allow them to be home as much as possible. We do understand at PHS the ever-changing needs of all ages of pediatric patients, from infants, children's, adolescents into young adulthood. We do carry over sometimes into young adulthood. Our multidisciplinary team basically provides them with a customized, comprehensive, and integrated plan of care from a home care perspective. Dr. Roy Maynard, who is here with us, is our medical director. He's a neonatologist and pediatric pulmonologist. He works with us at PHS to implement the latest clinical policies, procedures, and programs, and he also works to provide with the interdisciplinary of all those involved with the patient's care. So we have a whole team at PHS that I just want to kind of go and explain a little bit as we go. We have our pharmacy staff, which includes 4 pharmacists and also 2 pharmacy technicians. We compound all of our medications right at Pediatric Home Service in the pharmacy itself. They oversee a lot of our patients' needs. We work as a team, and I'll kind of go into that a little bit in the near future here. We have the infusion nurses. There's 9 of us. Our clinical manager, Michelle Curley, and then there are 8 other infusion nurses. We all go out into the field. We also have our 2, actually right now we have 3 IV coordinators who are the intake people at PHS, and that's Carletta, Janelle, and Doreen. And then we have Lynn and Chrissy, myself, Joel, and Mary Brown Kelly, and then Janelle. So we either are in the office or out of the office, but the majority of us are out of the office taking care of the kids out in the field. We have specialized nutrition services at PHS. We have 4 dietitians that work closely with us in the infusion department. You know, we have a lot of kids on TPN and enteral feeds, and so we work very closely as a team. They do consults. They follow kids that are at high risk out there, and they provide excellent education, and they also provide all those nutrition needs that those patients have. We also have respiratory therapists. Pediatric Home Service has a lot of high-tech kids on ventilators, trached, with need respiratory support, whether it's O2, BiPAP, CPAP, ventilator needs. So we have our respiratory therapists that are part of our team also. We also have started private duty nursing services. So we are doing the extended hour nursing out in the community now, out with the families. So those nurses usually do between 8 to 12-hour shifts, and they're the ones that are providing the in-home nursing for us with our PDNS department. We have Monica Hanlos, who's our medical social worker at PHS, and she also complements our services and does consults with the families as needed. She also does play therapy with our kiddos. So you guys often have child life and some of the other ancillary departments at the hospitals, but we have Monica, and she does play therapy for some of our patients who we refer her to for play therapy. We also have our DME and our customer service, so we provide all the durable medical equipment. Customer service takes all of the intakes, and they all provide that ongoing service of all the patient supplies and enteral needs, whether it be respiratory, enteral, IV. They provide all those services and ship supplies as needed. And then we have our biomedical support services. They're the ones responsible for making our equipment is working properly, for functioning. We do what we call PMNs, which we pull the equipment in on a regular basis to do all the safety checks. And everything that comes in as far as equipment to PHS doesn't go to the patient's home until it passes the biomedical department inspection and all of their computations that they need to do with our equipment. So, plan of care. We do a plan of care for each of our patients. They are created to meet their individual needs. We oversee their medication regime to keep them safe at home. We also teach the families all the necessary steps, and I'm going to show you some of those slide presentations of some of our teaching materials that we do in order to provide that medication regime to the kids themselves and to do that safely at home. We provide patient assessment, central line management, infusion administration, education, and lab monitoring. We offer skilled nursing visits and partner with other regional nursing agencies to deliver outside the 11-county metro area. So we do all the regional patients in Minnesota also. In the greater parts of Minnesota, we also do the greater parts of western Wisconsin. We carry into western Wisconsin a little bit. And I'll talk a little bit more about what we do from a regional case management perspective in just a couple of slides. So what's our referral process? When we get the referral from your discharge managers at either of the hospitals, any of the hospitals that we get, whether they're Children's from Minneapolis or St. Paul or Implants or Gillette, we also get other referrals from some of the other hospitals. We've had like from North Memorial. So basically the first thing that happens is Doreen or Carletta or Janelle, our IV coordinators, receive the initial phone call from the referral source. That information is then sent to the pharmacy as to what their needs are, to admissions and billing, and if the extended hour PDNS is involved, also to them. Once insurance and benefits have been approved or denied, then that information is sent back to the referral source. Once a referral source is notified, if we're going to be following that patient from PHS, then what we do is we set up an appointment either at the hospital or at the home, depending upon where the patient lives. Often if it's the home is if they're local within that 11-county metro area. If they're in greater Minnesota or western Wisconsin, then we usually will do the initial teach at the hospital because we'll be setting up with a regional agency to follow those patients. So the infusion case managers then are notified and they're assigned of their scheduled appointment time. If it's a regional patient, the regional agency is contacted. We do subcontract with other regional agencies in that area, and they're confirmed for services. Sometimes it's a little bit of a process because they have to confirm whether that insurance is going to be covered under their agency. Then we fax the orders, educational materials, and sometimes we actually even go out when we're doing our regional patients and do education in those areas. I've gone out to different areas to do teaching with the local nurses that aren't as familiar with central lines and infusion nursing to be able to go ahead and administer the care properly and safely at home. If interpreter services are needed, then we go ahead and have that arranged either at home or sometimes you guys in the hospitals, that's already done by the discharge managers there. So the initial teach is then done at the hospital or the home. We follow up with regularly scheduled visits with our patients. The visit frequency depends. Sometimes our TPN patients, when they're first discharged from the hospital, we may see them up to 3 times a week. Same with our transplant patients. Sometimes some of our IV antibiotic patients with a PICC line, for instance, we may see them initially and then we follow them on a weekly basis. It really depends upon what those orders are coming from you guys in the hospital and the discharge planners and the physicians. So we always do a 24-hour phone call follow-up once that patient is discharged and that initial teach has been done so that we can go ahead and make sure that, how did that first night go? How are things, because we may not see them for a few days or maybe even a week, and we want to make sure that any questions are being addressed. We also will do a physician's plan of treatment where we'll complete that treatment plan based on that patient's individual needs. We also do a care plan so that we can plan their care according again to their individual needs. And then we communicate any ongoing communication that needs to be done with the discharge planners, the physician, all the team members involved. We will also do that. Just wanted to let you know that we started an infection-free program. We call it our 1-2-3 infection-free program that we started several years ago. And basically, it's steps to take each and every time that you are going to be accessing a central line in order to reduce our CLABSI rate. We presented this poster presentation and they were passing it out. This one's not all that clear, but we did present that at NHIA, which is the National Home Infusion Association, and we also went to INS and presented our poster presentation in INS, which is Infusion Nursing Society. This is just kind of our current catheter days, our trends over since 2005. And if you look, our CLABSI rate is really, really low. If you look at right now, it's 0.23. It's been extremely low, our CLABSI rate. And we base a lot of our low CLABSI rate on the education that we provide the families and the nurses out in the home or the nurses out in the regional agencies. So basically with our 1-2-3 infection-free program, we talk about what we're going to do when we prepare. We set up a safe zone, we wash our hands, we place all our items on that safe zone, which is a drape. We practice scrubbing the hub, making sure we're doing that according to INS standards, not touching anything if we accidentally contaminate anything or the families do, starting over at that point. And then after the infusion, protecting by inspecting the IV site, the catheters, and reporting any symptoms to not only the PHS nurses, and those nurses are on call 24/7, so we always have an on-call nurse, but also reporting it to the physician if that needs to be reported to the physician. We created this as part of our 1-2-3 infection-free program, where we've created this daily catheter log for a week that talks about the bloodstream infections, the catheters, the needleless valve protection, the catheter site warning signs, and if they check those, then they would be contacting us. So our education to our families is really complete to make sure that we do everything we can to keep those kids safe at home. This is just a little quick glimpse of, this is just part of our education for what we, when we teach them the eclipse balls. I don't know if any of you, has anybody ever seen an eclipse ball at all? So just, that's how we administer a lot of our antibiotics, our hydration balls. And so this is just a little glimpse of what we do in our education department. Our education department consists of several people. Kathleen Urbane does plain language so that everybody can understand it. Shea Hintz is the one that does all of our education materials, and then they work with the infusion nurses to make sure that each step is put down in the order that it needs to go to and explained in a way that each family can understand it at a 5th grade reading level, basically. So we go step-by-step instructions with pictures that are really detailed so that it shows exactly what they're going to do, so that if they can't understand the language, for instance, they can look at the picture and they can pretty much know what they're going to be doing in the next step by the picture. We also created this quick reference guide for each of our different materials that we do and teach. So this one happens to be for the eclipse ball. Again, we have the step-by-step instructions, but then we do the quick reference guide so that once they kind of get used to it, they can pull out the quick reference guide and go down much quicker. We still ask that they do that because that way they'll never miss a step and they'll never forget something that should be done that's an important piece of that step. We do a lot of different types of IV therapy at home, anti-infectives of course. We do blood products. The only blood products that we give at home right now are albumin. We have several patients that are getting albumin. We do some biologic therapies. We do catheter care, of course, if they're just on cath care. Some chemotherapies and symptom management. Enzyme replacement therapy for glycogen storage diseases. We've done Aldurazyme, Myozyme. We have done VPRIV in the past. Hydration, of course. IVIG. Inotropic therapy for heart failure. We've actually had several kids on milrinone drips at home, both pre and post heart transplant. We've actually just gotten a couple of the kids off their milrinone drips just recently. We do pain and palliative and PCA therapy at home. We also do a lot of post-transplant monitoring, medications, lab draws. We have a lot of kids that have TPN and lipids needs, so some of our short gut kiddos that we see, and we have a lot of kids with gastroschisis that come to us with TPN and lipid needs. And then we also have some other specialty therapies. One of them is spin and drain. We do, as infusion nurses, always carry an adverse drug reaction kit with us, and we are well prepared for any type of adverse drug reactions with our patients. We also do non-IV therapy, so sub-QIG. We do a lot of education on sub-QIG administration and allow the parents to become independent on that. We do peripheral and capillary lab draws, Lovenox and Insufflons, a lot of enteral education, food pumps, and enteral education regarding NG or NJ, G-tube, GJ tubes. We also do non-IV skilled nursing visits. Sometimes we have our cardiac kids that come to us that don't have any infusion needs, but they need 2 or 3 times a week on non-IV skilled nursing visits just for assessments on them. And then we have Carletta Crawford, who's our wound ostomy. She's kind of specialized in that. She hasn't actually gotten her certification yet, but she's done all the coursework up until this point right now. So we consult with her for wound ostomy. As far as our adverse drug reaction education for our families, we make sure that we train them so that they are aware of the signs and symptoms of the adverse drug reactions from hives up to anaphylaxis. Like I said before, all of the RNs that are doing the infusions, we do carry the kits with us and are well prepared to handle any type of emergency if we have those reactions, and we've had a lot of times where we have those reactions. Certain therapies that are provided in the home necessitate for the kids to actually have their own ADR kit, kind of a mini ADR kit in the home, so we make sure that they have them as appropriate. And typically we ask that PHS's policy is that the first dosing of any type of medication that could have a potential for adverse reaction is typically done in the hospital or the short stay unit, and then we take over that care once that's been established that that's safe care to complete at home. As far as our PHS infusion education, we want to make sure that we ensure quality at home. We develop a safe plan of care that's grounded in clinical education and technical support, and that, like I said, it's plain language, a 5th grade reading level that all of our materials are done in. We do classroom instruction, both internal for our nurses internally and also externally. We have a lot of nursing agencies that send their nurses to PHS for their infusion classes and education. We do one-on-one mentoring, and we follow all standards for infusion nursing based on INS standards. These are the list of our education classes that we offer. So PEDS assessment, IV basics, also it covers a lot of the central line, caring for an implanted port, TPN lipids and ambulatory infusion pumps, starting a peripheral IV, drawing blood specimens, and that's capillary, peripherally, and from central lines, home care documentation and legal issues, and then also safety infection prevention. So basically what we do is we specialize in helping kids be kids at home, no matter what their medical challenges. And our motto at PHS is that PHS kids thrive. So I'd like to open it up to any questions that anybody has. If you have any specific questions about what we do or how to make the process easier.
I have a question about the referral process. Typically from that first phone call that the IV coordinator makes to you guys to act, when the patient is discharged, to actually being able to go to their home or the hospital visit. What's the typical turnaround?
Well, it's variable. Sometimes we get a phone call at 3 o'clock on a Friday afternoon and they want to ship them out by 5 or 6 o'clock. And so, we send that template through to billing. We mark it as urgent, and we try to get an answer from insurance before they're, so that we can get them out, by 5, 6 o'clock and get them out. So it's variable. We send it immediately through. If it's a same day discharge, then we mark it as urgent so that process is sped up. Other questions from anybody?
On the classes, if anyone wants to take one of the classes, they're all free of charge for the nurses. So,
What did you say?
on the classes, they're all free of charge. If you're interested in attending one of our classes at the office, you can just sign up.
It's in Roseville, right off of County Road D and 35, really close to Roseville Mall. Yes. Oh, yeah. Well, like I said, we have an on-call nurse 24/7. So, yeah, you call people on the weekend. Yes. So, you know, sometimes we get referrals on the weekend. So, whatever nurse, the on-call nurse for the weekend starts at 5 o'clock Friday and goes to Monday at 8 o'clock. So, we'll get the call directly to us. You call PHS number, ask for the infusion nurse on call. They'll take that referral. They'll get that information all processed, and they'll come out and do the visit for them. If we have a question, if we get an on-call referral over the weekend, we typically will take that patient. You know, typically we can't verify insurance until Monday morning. But typically we'll at least start the patient, or else if it's really a question as to whether or not we can take them, then typically what we do is we'll call the on-call manager and they'll get the answer for us.
Chrissy is our on-call nurse tonight, so anytime there's always a nurse that's on call.
Yep. Roy, do you have anything you want to add at all?
No, I think one of the big differences I think between being a hospital infusion nurse and a home care nurse, they don't have a resident or a doctor in the home. They're at home administering these drugs, and if you've done any enzyme replacement therapy, you know the risk for reaction is very, very high. Enzyme replacement therapy, they're at home by themselves, a little bag of medical drugs and just that anaphylactic attack done. So there's a lot of independence to be an IV
Any other questions at all? All right, well, thank you.
Thank you.